Home care, by definition, provision of equipment and services to the patient in the home for the purpose of restoring and maintaining his or her maximal level of comfort, function, and health. And in many cases, just comfort and function, as health is not going to improve. Osler of Osler's notes from back in rheumatology and other locations in medicine history, it is much more important to know what sort of patient has the disease than what sort of disease the patient has. You know, people, it is generally considered inappropriate to say, oh, he's an arthritic, because that makes him the disease. He's a cardiac patient. No, he's Mr. Smith who has a cardiac condition. So we get that, he's a diabetic. Well, you know, you get what I'm saying. So we almost just automatically routinely do it. And you probably shouldn't do it. Home health care. Okay. Considerations for initiating home care is that, first of all, the service can be provided in the home. And there's some pretty elaborate things in the home. I mean, hospital beds. I've seen people with respirators. I had a lady that I took care of who had diabetes for about 15 years. And she had a daughter who had an accident that led to asphyxiation, and she ended up with brain damage and a seizure disorder. And she was basically in a coma, and she was just there. She kind of came out of the coma, but she was unable to walk and move around. She kept her in her home. She kept her on a respirator. She did all the care of all the machines, and she took care of her daughter who also had diabetes. So she injected insulin, she took care of herself. So pretty much every visit she would come in, it's always like, tell me how you're doing, how's your daughter doing, because that was basically her life. Then when her daughter died, she finally got an upper respiratory infection that became a lower respiratory infection, and she died. Then she didn't know what to do with herself, because she had for always been, you know, confined and trapped at home, taking care of her daughter, which she really wanted to do. We talked about it a lot. Do you need help? Is this what you want to do? Do you feel like you need a break? No. And she was really serious about that. That was her life. She did that. But service can be provided in the home. Safety can be done safely. Is there safety in the home? Patient autonomy. Transportation barriers might be an issue, so that the back and forth to facilities is harder. The expected outcomes have to fit a home care situation, and it has to be something that can be cost effective for them. The Medicare requirements for home health is that the patient is homebound, and I'll give you a definition for homebound in a minute. The patient needs intermittent skilled nursing, physical therapy, and/or speech therapy. The patient is under a physician's ongoing care. That's the Medicare requirement. What does homebound status mean? It's actually an official status that Medicare will give a person. They're homebound. Patient can leave home infrequently for short durations, like for outpatient medical care, religious services, or adult day programs. So that doesn't completely restrict them from getting out of their environment to be homebound. The Medicare covered services are intermittent skilled nursing, less than 7 days a week, less than 8 hours a day. They have skilled therapy services, which are PT, speech therapy, or occupational therapy, which can either be restorative to get them back to a certain point, or just maintenance of where they are. Home health aides, and a medical social worker. Okay, so here's some of the things you see: physical, occupational, speech therapy. Okay. Skilled nursing can be done in the home. Responsibilities of the physician in the management of the home care patient. Management of medical care. Coordinate the need for durable medical equipment. Just supplies, glucometers, all the CPAP machines, things like that. Coordinate need for lab, x-rays, and med adjustments, and review the plan of care as needed. Okay, now a PA can do all of the in-home stuff, but there still has to be a physician of record the way Medicare has put it together. Now they may change their rule at some point, but right now this is it. The new home health care face-to-face encounter requirement kind of was put in place a couple of years ago. Purpose is to affirm the role of the physician as the person who orders home health care based on examination of the patient, which must They must have examined the patient within 90 days prior to the start of the home care or within 30 days after the start of care. You might say, how does that happen? Okay, if ordering home health care for a new condition that was not evident during a recent visit, the certifying physician must see the patient within 30 days. For example, they go in, they already have kind of poor health and they have a major episode, go through the emergency room, hospital, and come back out in home care, and they haven't been to their primary care provider's office, but they are in contact. They set it up, and then he has to go see him within 30 days of putting that together. When you first read that, you go, what? You know, how are you going to do that or pull that off? Let it be that situation. The face-to-face can be done by a non-physician provider, but a physician still must order and certify the plan of care. So it's possible to be involved in homebound care, and I know people who do that. Now hospice, another form of homebound care, just a different focus. This covers, Medicare's hospice benefit covers palliative and support services for beneficiaries who have a life expectancy of 6 months or less if the terminal disease with which they have been diagnosed follows a normal course. So it has to be expected at 6 months. Agree to forego curative treatment for the terminal illness. Do not resuscitate is not needed because they're expected to die anyway if you don't do anything. And 2 physicians have to certify initially, so it just can't be 1, 2 people have to say that it's a terminal condition. The first hospice benefit period is 90 days. If the illness continues to engender the likelihood of death within 6 months, the patient can be recertified for another 90 days. After the second 90 days, the patient can be recertified for an unlimited number of 60-day periods as long as he or she continues to have a life expectancy of 6 months or less. So what they're saying is, you go in with the notion of 6 months or less, but if the person hasn't died then, but they still think that's the likelihood, then you can extend it out. So it is possible to actually be in hospice for a while by the law of Medicare. It doesn't usually happen, but it could. The hospice benefit team, medical director available 24/7, skilled nursing available 24/7, chaplain, aide, social worker, durable medical equipment company, and pharmacist. Overview of what the team does: they develop a plan of care, they manage pain and symptoms, they attend to emotional, psychosocial, and spiritual aspects of dying and caregiving. They teach the family how to provide care. They advocate for patient and family, and they provide bereavement care and counseling after death has occurred. Okay. It is not traditional Medicare fee-for-service. Daily payment is available for all related care, and there's 4 levels of care defined, very much like in outpatient care, and y'all will get more disability code and stuff later. But in outpatient care, there's 5 levels of establishing a patient, and there's 5 levels of follow-up visits for established patients. And some of y'all may know that from having, if y'all are scribes and doing stuff like that. 99211 through 99215 is established, and then 99201, is the first visit to get people in practices. So there are hospice houses, that where a person can go if they really can't do it at their own home. See now. Here's what Dr. Kuhl says, what dying people want. The experience of learning about a terminal illness can propel people into search for a true self, a search for healing, for the courage to care for psychological wounds. It is the only way to live life to the fullest until one dies. One discards what's imitation and embraces what's real. This is a continuous process which seems to move people from depression towards hope, through anxiety towards peace, and from despair towards integrity. If you read Ivan Illich, that's exactly what he talked about. He was so worried about fake and stuff that's not real, and moved towards what was real, eventually kind of relaxed in what was real, and saw how fake so much of stuff had been. Okay, so we'll escape that one, and then we'll do this one. advanced care planning and advanced directives. How many of y'all have been involved in advanced care planning and the drafting of an advanced directive? Okay, so several have. Can you tell me what's your experience?
Just my parents.
Do it with them?
Mm-hmm.
So y'all have done advanced care planning and you got all that stuff put together?
Mm-hmm.
What about you? Same thing? Amanda?
Grandma and yeah,
Okay. Was the whole family there when y'all made decisions?
yes, and we were sending them like the power of attorney kind of thing all at the same time, so it was a lot of people.
Yeah. Mhm. You know, when I did the chaplaincy for 6 months at OU Medical Center on the weekends, one of the jobs of the chaplain was to actually approach people about advanced care directives when they would come in with any diagnosis. It was pretty amazing. It was part of what needed to be done. And there were some people where you need to have it done. I was surprised how many people didn't have anything. I mean, like most people never had it. And some people would be, well, I don't need that. And then some people were like, oh, they would be glad to have it. So it's just kind of not a discussion that comes up amongst people. Okay, advanced care planning is discussions with patients and or their representative about their goals, desires, and preferences directed towards the patient's health care, particularly in end of life. It's often documented in writing, so here's some things that are kind of places where writing can happen. Advanced directive, living wills, another way to describe it, electronic health record, physician orders for life-sustaining treatment, POLST, or medication orders for life-sustaining treatment, MOLST. Part of that advanced directive always puts down there, if you're unconscious and not expected to live, do you want food? Do you want water? Do you want respirator? Do you want, pain medications? I never saw anybody not check the pain medication box. I mean, nobody wants to, who chooses pain? No matter, it would not be usual to do that. It can be a guide for the patient and their loved one about healthcare decisions, especially in the event the patient lacks capacity to make decisions. So it's really important to do this when you're in your best mind and not under pressure of any sort. Why should you care about advanced care planning? Well, there's a law. Okay, 20 years ago, Congress passed the Patient Self-Determination Act, PSDA, requiring most healthcare facilities to inform adult patients about their rights to execute an advanced directive. And that was my job. That was what I got to do when I was doing chaplain role. Previous studies have found that 20 years after PSDA was passed, population-based prevalence estimates of complete advanced directives among adults in the U.S. range from 5 to 15%. Which pretty much fits my experience because most people do not have that, put together. However, 28% of home health care patients, 65% of nursing home residents, and 88% of hospice care patients had at least one advanced directive on record. It's hard for me to believe that hospice is not 100% because if you're choosing to end life, then, why don't you have an advanced directive? Maybe they felt that hospice care was pretty much a signal, I'm not going to do anything anyway based on the requirements to be in it, that they didn't need it. So, kind of just a quirky thing to me. Oklahoma law, last time when I taught this, it was in 2017 in May, spring 2017. And at that time, Oklahoma did not have surrogacy laws, which means who can make a decision if there's no decision made by the person. There was not a law until November of last year, so it's not even a year old yet in Oklahoma. Kind of stunning, but it was the case. Okay, before this date, last year, family members had no legal authority to direct healthcare providers if the patient failed to appoint a healthcare proxy who's in charge of you or an agent under a durable power of attorney. However, this was often ignored by healthcare providers. See, the law is if there's no directive given, the healthcare provider does what they need to do. But what healthcare providers would do what they need to do if the family's around, even though it's not executed, there's no hierarchy, you still want to talk to people. I mean, for heaven's sake, you might end in a lawsuit. If you don't do things a certain way, that's why you get people to sign paper. It's important. So it's called Title 63 Oklahoma Statute, Section 3102.4, which I do not remember, nor expect you to remember. Establish surrogacy hierarchy for patients incapable of medical decision-making. Here's the new hierarchy for Oklahoma. And it varies in different states, so this is just what it is here. If you go somewhere else, you'll have to figure out what they do in those locations. But guardian is first. Isn't that interesting? Guardian, legal guardian, healthcare proxy, that can be signed away in the advance directive. This is my proxy. And I've given y'all a sample Oklahoma advance directive piece of paper so you kind of see what they ask in here. Durable power of attorney is third. Patient spouse, if none of the others above apply. Adult children of the patient, parents of the patient, then adult siblings, then other adult relatives in order of kinship, and close friends of the patient. You can imagine in some situations the family's so broken down that it's kind of hard to follow the surrogacy rules. There actually are, I was reading some stuff last night, just kind of interesting, that now that the law's in place, there are exceptions to this. If you are a healthcare proxy but you're a convicted felon, you can't decide. So there's things that happen to you when you do things. If you are a child molester or you've been accused of battery or some attack on a person, you can't do that person even if you were named. So there are other rules to look at besides this, and there can be contesting. It can be that this person offered out proxy to you in good mind, but now you are manipulating to get property. Okay, so let's say a husband and wife, they sign for each other and they hate each other. And then the wife is now in a dependent condition and the husband is making decisions to get stuff that the wife had. Family members can come forward and say, he's doing that because he wants to get this, and if you can prove that, then you can stop the decision making. So, I mean, stuff can be messy in the real world, I mean, no doubt. And anymore in this day and age where there are multiple levels of relationships, it used to be single marriages that lasted, and then maybe there was a divorce. Now there's remarriages, and there's different levels and stepchildren. I mean, there's just all kinds of complexity that can be part of contesting. So, but this is the surrogacy. So there's surrogacy hierarchy in Oklahoma for decisions if the patient never signs anything. Okay. Here's like naming a proxy. Here it reads like this. This is part of the little piece of paper I've uploaded a blank one that we used to take around. If my attending physician and another physician determine that I am no longer able to make decisions, see, that's the two people having to decide that somebody's terminal. Regarding my health care, I direct my attending physician and other health care providers pursuant to the Oklahoma Advance Directive Act to follow the instructions of blank, whom I appoint as my health care proxy. If my health care proxy is unable or unwilling, for example, they got convicted of selling meth, then I appoint blank as my alternate. And you can actually go down more if you wanted to, if you were going to name them out. My healthcare proxy or alternate is authorized to make whatever healthcare decisions I can make if I were able regarding medical treatment, including life-sustaining treatment and artificially administered nutrition and hydration. Okay, family perspective on end-of-life care. Bereaved family members reported higher rates of unmet needs. Here's what the people say. If you've got somebody who's dying and you're around that person, what is their experience of the whole situation? Well, here it is. It's not a good system, not a good record. They felt like they had unmet needs for symptom management, that there was suffering that didn't need to happen. They feel that there's unmet needs for communication from physicians about medical decision making. What's happening? Why are y'all doing this now? What does this mean? There were unmet needs for emotional support for themselves. It's just kind of like you get so focused on who's in the bed that you kind of forget who's around the bed. And then respect for they felt there were unmet needs for respect for their dying family member. That's not a good thing either. I've seen it. When a person is not conscious or responsive and they are dying, and that practitioner is busy with so many other things, they can move in and move out very quickly, and it comes across as very disrespectful, and you just check the numbers and check stuff and make comments to other people in your team, well, she ain't going to be here much longer. And they will hear that. I mean, just stuff like that. That comes across as just completely insensitive. I told y'all about, did I tell y'all about the organ donation gap that I was part of? Did I tell y'all that? That I was in the room when the woman was dying, everybody wanted organ donation except the daughter. And the daughter had this emotional relationship with her mother. But the mother wanted to do organ donation, but nothing was moving forward. And this was before the surrogacy laws, because she was having a fit about her mother being organ donor. She didn't want it to be done. She didn't want her body taken apart. And eventually, I remember talking to the family, all of them, and one of her sisters came out and she said, this is what she wants, what do we do? And I said, y'all have to talk to each other. You have to come to an agreement on your own. I'm not going to tell you what to do. She said, well, you go in there and tell her. And I said, I cannot do that. I said, I can tell her what the mother's wishes are if they're in print, which they weren't in print. There was nothing going on. So I said, we really can't do anything. They said, well, they eventually got to the place where she would, the daughter said she would listen. So life, what's that thing called? Life, thank you. I was being the wrong word. Life Share came. They had this 28, 29-year-old new person who had just trained, biggest debacle I've ever seen, came in the room and started talking about what they could do, and the nurse is there, chaplain standing there, and then the family's all around the bed, and the daughter's holding her mother's hand, and this person, I mean, the most insensitive dirt clod I've ever seen, started talking about, well, you know, they said, well, what will happen? Well, we can take all kinds, we can take organs, we can take her retina, we can take her liver, we can take her whatever, and they said we can use her bones, and then the daughter is just shriveling as she sees her mother being deconstructed. And then he said, it's funny, I may laugh when I say this, but it was not funny at the moment. He said, well, we'll put her back together in the casket. She won't be like a chicken without bones. I loved you. I was sitting there, we were sitting there, and the nurse was like, she's like, you are done. I mean, we just said, okay, thank you, just heard that sucker out. And this girl is just blowing up. Thought, that's it. You know, the family was so upset. They, you know, it kind of went on for several more hours. Eventually, the woman did become an organ donor. She died, and they took her down to harvest organs. But I don't think I've ever seen anything like that. I mean, I don't think I've ever seen anything like that. Can you imagine? I mean, it was just like, do you have any presence of mind here? I mean, it was totally ridiculous. Absolutely true story. We did report that person to Life Share because they simply can't afford to have that type of personality in rooms, because it doesn't help people who could benefit. And it doesn't help the family who's willing to be a donor. Lord. Okay. Okay, that's it. Studies on communicating prognosis. Doctors, this is what they have found when they look at how doctors communicate prognosis. Doctors emphasize treatment and downplay prognosis. Okay, you're trying to deliver hope. There's things to do. Disclose actual beliefs 34% of the time. So they really don't tell you exactly what they think is going to go on with that person. They withhold prognostic information from 25% of patients. They don't tell them they're going to die. And, you know, there's some people you can't just walk up to and say you're going to die. You know they know, but they don't need you to say it because it's like a nail. You know, it's very difficult. So let's talk to them about, you know, we're in a difficult spot. You're in a difficult place. We're going to take care of you. What needs do you have? Okay, you just kind of put it out there. Then they might come back and just leave them alone. You don't have to say, and you're probably going to die. Don't say that. Then you come back later and they might go, I'm going to die, aren't I? And then you can say, that's likely. Okay, then but you just walk into, you have to go into the rooms a bunch of different times. You just have for little bits of time to stay connected, develop the relationship, don't hurry things, be sensitive, let them open, and then you kind of move through it. Okay, they give deliberately optimistic estimates. Nobody wants to be the Grim Reaper. Okay, Medicare reimburses for advanced care planning. In January 2016, so you see how recent all this stuff is, Oklahoma in last year, Medicare in 2 years ago. Part B allows for 30 minutes discussion for advanced care planning in a clinic or a hospital. The document, this is just some interesting details. There's codes for it now, 99497 for that alone. So you could do advanced care planning as a visit in clinic, and that's all you talk about. Or you could bill for that if you saw them for something else too. They will pay up to $75 for 30 additional minutes of consultation. So you can bill, look, $150 plus for advanced care planning, which is worth every penny when you get to the end, when you think about it. It may be reimbursed if conducted as part of an annual wellness visit. How many of y'all have done annual wellness visits? Do y'all know what those are? Okay. Medicare requires an annual wellness visit. It goes through a bunch of stuff. You know, weight, healthy lifestyle, checks blood pressure, you know, all the different vital signs, reviews meds, looks at vaccinations. It's just all these things that need to be done. Women, DEXA scans for osteoporosis of a certain age. And they will also let you do advanced care planning as part of that visit. Those visits pay a lot of money. A wellness visit is like $150 to $160 because it takes about an hour. It's a long deal. But if you do advanced care planning as part of it, they will tack that onto the bill, so you can get paid for the wellness visit and that. And it's kind of a good place to kind of batch it all together. Okay, minimum documentation required. Person designated to make decisions for the patient. If the patient cannot speak for him or herself, you have to document that if that's the case. Type of medical care preferred, the comfort level that is preferred, the patient consent for advanced cares performed as part of annual wellness, as we talked about that, and additional information, how the patient prefers to be treated by others, what the patient wishes others to know. Adequate documentation also requires for indicating these other orders that can be followed. The extras, documenting the EHR. Okay, power of attorney. A power of attorney has a lot of authority in a lot of ways as a surrogate for somebody else. So I'm a power of attorney for my mother, so every bank account we've got in dual names, all the insurance, everything. And it's really helpful because stuff can just move on. I can just sign, it's done. And so you have to get that in place. And they have to give it to you while they're of right mind, unless you have a court-ordered kind of deal going on. Code status, medical and comfort preferences, organ donation, that's a good one to discuss. I'm not an organ donor, I'll just tell y'all. I just got my driver's license renewed, I'm not an organ donor. I just don't want to do it. And I don't, you know, it's just one of those things, it's not required. A lot of your generation is organ donors. So most of y'all organ donors? Okay. It's just call me quirky. I just want to stay intact. Okay. I don't know what's going to happen to me, but I don't want to take it apart. Who knows? Okay. Burial preferences are there. That can be helpful. And which funeral home, those things can be thought about in advance. That was interesting because at OU Medical Center, there would be people who would die and no family were around, and you would call the family, find the numbers and call, and they would go, oh, she's dead, good, I don't want anything to do with it, and not take the body. The first time I heard that, it's like, you are joking me that people will not take a dead body. It's expense. And if they're from a poor background, then they don't want to have to worry about that. So the body goes to the morgue for 30 days in Oklahoma, and if nobody claims the body after all efforts, then it is handled by the state. Isn't that crazy? This happened for babies. I remember there would be babies that would die in the labor and delivery or in ICU from very impoverished parents, and they would not claim the body. It was in the hospital, so to them, if the baby dies in the hospital, it's kind of a blessing because you don't have to bury the baby. I still can't quite get over that refusal to, you know, lay the remains of your people in their place. You know, it just doesn't seem right. Okay, and then physician orders for life-sustaining treatment. That gets into, do you want food, do you want water, do you want pain medications, it's things like that. Okay, you can have little cards, you carry cards that indicate you have it, and you know, copies are held by, so if you get somewhere. And then here's some resources, just books, Mastering Communication with Seriously Ill Patients. It may be something you need to worry about, it may not be. depends on your venue of practice, you know, so some of these things are more helpful. If you're in a hospital, it probably is more helpful because you have more acute illnesses. But if you're in an outpatient clinic and you know people for years, let's say you're in a family medicine practice in an area, they will know you like a family member, so it may be a dialogue that will come up over time. This is the guy that we saw earlier about being moral medicine and what matters in the end. And then let's see what this little clip will give us.
One of the reasons I write is it gives me my chance to dive into problems that I'm very confused about. I've written about, you know, what are we supposed to do about the cost of healthcare? Why is the malpractice system so crazy and what's the way it should be? I've written about why do we itch? You know, if it's confusing and interesting to me, writing is my way of diving in and figuring out what to at least think about it. And this was one of the big ones. The two big unfixables are aging and dying. You know, they're not, you can't fix these. We're afraid of talking to the patient about these problems as well. A lot of doctors feel like, I know how to have this conversation, I know exactly what I'm doing. But what I knew, what I could see over and over again, was that we weren't particularly good at handling people going through the last phase of their life. I've had to learn that because of patients with whom, you know, they did not end up with a good experience at all. And then I've had to learn it the hard way because of my dad.
Do you remember when Dad first started to get pain in his neck?
He thought either playing too much tennis or just muscle.
And instead what they found was a tumor, a huge tumor.
I remember I took notes in my journal around that time. And my dad saying, the way things are going, I could be bedridden in a few months.
The tumor had extended into his midbrain. The suggestion was that we should go see what options there might be for chemotherapy. So the oncologist lays out 8 or 9 different options, and we're swimming in all of it: temozolomide, vincristine, vinblastine. And my dad says, well, what if I don't take any? And she said, well, that's your choice. Then started talking about how, you know, you really should think about taking the chemotherapy. Who knows? You could be playing tennis by the end of the summer. I mean, that was crazy. It made me very bad because it was
Completely not right, yeah.
You know, this guy is potentially within weeks of being paralyzed. It was holding out a hope that was not a realistic hope in order to get him to take the chemotherapy.
When he made the final decision that he doesn't, you know what to, I told him, for me it's okay if you're paralyzed, so what? I can take care of you. You know, and that's the main difference. It was not fine for him.
The oncologist was being totally human, and the oncologist was talking to my dad the way that I have been talking to my patients for 10 years. But hope is not a plan. And in fact, we find from our trials that we are literally inflicting therapies on people that shorten their lives and increase their suffering out of an inability to come to good decisions.
Okay, other resources, a game, kind of a card game. Another resource, 5 wishes, what people would want. Okay, so this is not the most pleasant stuff to look at, but I will tell you, it really kind of delves into an aspect of health that you really don't necessarily want to indulge all the time. But it kind of puts up before you what is health and what is a good outcome, and how do you navigate when you're in various straits of a person's life. And, you know, we spend a lot of time talking about how to fix things and make things better, but also there's ways to fix things and make things better at the end, because everybody has a finite, you know, time. And it's worth talking about, it's worth thinking about, you don't have to dwell on it, and you don't even necessarily have to be prepared to deal with it yet. But I hope this at least introduces the concept, and you have some things to look at and to begin to work with as you kind of find your own way of dealing with this, to whatever way you can deal with it, as a healthcare provider. Okay, so I hope all this kind of got you to a new place. So we went all the way from hospital to